Hi, this is Martin Uram. Let's look at the glaucoma applications for laser endoscopy. The primary goal is to effect endoscopic cyclophotocoagulation, or ECP. There are two sets of componentry to perform ECP. The first are the laser endoscopes themselves. These are 20-gauge handpieces that combine imaging, light, and laser. There is a central core of imaging fiber surrounded by a plurality of light fibers and one embedded laser fiber. This permits a 110-degree wide field of view, a 110-degree wide cone of light, and somewhere in all of that will be the laser beam. The second set of the componentry is the console itself that contains a high-resolution video camera, Xenon light source, and 810 nanometer diode laser. When learning ECP, the surgeon must acquire 4 skills. The first of these is to watch the video monitor instead of the operating microscope. Second, we have to learn how to access the ciliary processes given the approach, either pars plana or limbal, and the patient's lens status. The third skill to be learned is how to inflate the ciliary sulcus when there is a lens behind the iris. And finally, the surgeon must learn to control a long-duration invisible wavelength laser. When performing ECP, the first consideration is anesthesia. The anesthesia required to perform ECP is fairly straightforward. Retrobulbar, peribulbar, or intraocular anesthesia is perfectly adequate. If the surgeon elects to use topical anesthesia, then just prior to ECP, intraocular lidocaine is required. The ciliary body is very sensitive to laser application. The next question is the incision, especially with regard to an anterior segment incision, whether clear corneal, limbal, or sclerocorneal. A generous incision is best. Typically, 1.5 to 2 millimeters is the minimum required for ECP. It is a negative feature to have a tight wound because as the surgeon manipulates the endoscope, there is torsion on the cornea that will result later on in Descemet folds and blurred vision. If, however, there is a generous incision, then the surgeon may move the endoscope laterally in the wound while manipulating the endoscope, and the cornea will appear to be quite nice the next day. When accessing the ciliary processes, the surgeon must have in mind the desired tissue effect. There are 3. The surgeon should whiten the ciliary processes, watch the ciliary process tissue shrink, and treat the entirety of each process if possible. Another issue is how large to make the treatment zone. As we go into the specific mechanisms of glaucoma, there is some variability. But the short answer is that in most situations, that is, except for neovascular glaucoma and some pediatric forms of glaucoma, 270 to 360 degrees of ECP is required. The histopathology of ECP has been well studied, and it has been found to be specifically ablative to the epithelium of the ciliary body only, sparing the underlying muscle, sclera, and nerves. In addition, there is great value in being able to directly view the target tissue. In this way, the surgeon can avoid overtreatments, undertreatments, and incorporation of non-ciliary process tissue or prosthetics in the treatment zone. It should be noted that transscleral cyclophotocoagulation uses approximately 5 times the laser power that endoscopic cyclophotocoagulation applies. This 5 times power is lost in the eye somewhere, creating tissue damage and its attendant effects. All of these issues are clearly avoided with endoscopic cyclophotocoagulation for no other reason than the target tissue can be clearly visualized and the laser controlled in a much more meticulous manner. Now let's examine how to access the ciliary processes given the approach and the patient's lens status. There are 2 basic approaches, either anterior through a limbal type incision or posteriorly through the pars plana. Let's look at the various iterations of accessing the ciliary processes and some of their associated clinical examples. In this eye, there have been 2 previous trabeculectomies that have failed, and the intraocular pressure is uncontrolled on maximum medical therapy. One can see that the lens is pushed well posteriorly and that there is an excellent view of the entire ciliary process. The zonules are very thin and wispy. The ciliary processes are turned white and slowly photocoagulated, making sure that the burn spreads into the valleys between each process. Notice in the distance, the peripheral retina can be seen. As photocoagulation proceeds, more and more of the ciliary processes are treated. Recall that 180 degrees is about the most that can be treated through a single incision using a straight endoscope. Notice that the zonules in some of the processes are actually quite stretched using this much viscoelastic. Still, one can see that the zonules are not rupturing and the lens is quite stable. Because the lens is actually below the laser endoscope, it is not being traumatized. One will see a small orange area on the underside of the iris. This represents the membrane closing off the internal aspect of the sclerotomy site created for this failed trabeculectomy. Once the laser endoscope is advanced as far laterally as possible so that no more ciliary processes can be accessed, then the surgeon directs the endoscope in the opposite direction to get the remaining 90 degrees. In this way, 2 quadrants of 90 degrees each can be treated through a single incision. This is a patient with open-angle glaucoma and pseudoexfoliation who is also phakic. The endoscopic appearance of pseudoexfoliation can be quite striking. One of the features that is the endoscopic hallmark of pseudoexfoliation are markedly thickened zonules. In the previous cases, the zonules were barely visible. One almost had to imagine them. But here, long, lax, very thick zonules can be seen. There is also white pseudoexfoliative material on the zonules and on the underside of the iris. This is a case of inadequately controlled intraocular pressure in an open-angle glaucoma eye with posterior chamber intraocular lens. It also serves to illustrate one of the biggest mistakes that novices of ECP make, namely that the sulcus is inadequately inflated. In this situation, the limbal incision is fashioned with an MVR blade and then the sulcus inflated with viscoelastic. It is important to use a sodium hyaluronate viscoelastic. Even though all appears to be done well, when the laser endoscope is inserted, one can see that the iris is pushed forward, yet it is very difficult to view the ciliary processes, and the lens implant is still in the way. Notice the air bubbles also injected with the viscoelastic. These are not very helpful either. To remedy this situation, one must merely re-inject more viscoelastic. Now when the sulcus is viewed, we could see the entirety of the ciliary processes and have a very easy time of accessing them and photocoagulating them. Notice that the bottom of the picture is the anterior capsule of the lens, the edge of the capsular rhexis, and the optic of the lens. The top of the picture is the underside of the iris and pupil. Once again, long-duration photocoagulation lesions are placed on the surface of the ciliary processes in order to achieve the desired tissue effect. In this eye with uncontrolled open-angle glaucoma and a posterior chamber intraocular lens approached from the limbus, the laser endoscope is supplying energy that is too intense. The ciliary processes are immediately exploding. This creates inflammation, bleeding, pain, vision loss, and all of the other perceived complications of transscleral cyclodestruction. In this situation, one need only decrease the power delivered to the laser endoscope by adjusting the console, or by having a shorter duration application, or by moving the endoscope further away from the target. In this overly intense treatment, one can see retraction of the zonules. There is actually rupture of the zonules focally at one point. This does not destabilize the lens, however, one must take care not to repeat this. This is a patient with uncontrolled open-angle glaucoma who underwent combined phaco-ECP. The lens implant has already been placed and the sulcus is well inflated. As you can see, the ECP is quite simple to perform and does not destabilize the lens. This also gives the surgeon the opportunity to inspect the periphery of his capsular bag to determine if there are any residual cortical material. This is a patient with a failed Maltino implant that underwent combined phaco-ECP. Once again, the capsular bag has been emptied of its contents, the lens implant placed, and the sulcus inflated. The presence of the Maltino tube in the anterior chamber is of little consequence. This is an eye with uncontrolled chronic angle closure glaucoma and previously failed trabeculectomy and transscleral cyclophotocoagulation. One can see the previously treated areas of TSCPC and the fact that they were too posterior or anterior and missed the ciliary processes. Again, when operating on an eye that has failed previous transscleral cyclodestruction, a search is made for the viable processes, and then they are photocoagulated as if no prior treatment had ever occurred. When changing to a different limbal incision, a view in the anterior chamber shows the chronic angle closure nature of this eye. Going through the pupil and now accessing the ciliary ring, one can see capsular and cortical remnants obscuring a view of the ciliary processes. It is best not to disturb these. One can either laser through them or around them, but addressing them surgically defeats the whole purpose of ECP, which is to be minimally invasive, to basically slip in and slip out of these eyes and not disturb any of the tissue other than apply laser to the surface ciliary epithelium. In this eye, overly intensive application to the ciliary processes resulted in explosion of tissue. One or two of these usually will not cause serious problems, but repeated offense will result in complications. This is an eye with failed trabeculectomy and chronic angle closure glaucoma. The lens implant is displaced a bit anteriorly while inserting the laser endoscope through the limbus, and one can see nicely through the sclerotomy site into the subconjunctival space. The ciliary processes are easily accessed and photocoagulated. This is an eye that responds very well to ECP, which can be performed in a few minutes, whereas more conventional treatment by repeated trabeculectomy or by tube implantation certainly requires greater surgical intervention and is also associated with a lower success rate and higher morbidity. This is an eye with post-penetrating keratoplasty glaucoma. Although it would be possible to access the processes through the anterior chamber, it is far simpler to go posteriorly and not deal with any architectural derangement of the anterior segment. When the approach to the ciliary processes is not adequate by this method, one may combine ECP with scleral depression, pushing the ciliary processes into the view, as well as revealing the valleys in between each process allow for complete treatment and, most often, a good outcome.